All right. I think it's 5 o'clock and we have a quorum. So we'll call this meeting to order of the Board of Trustees of Integral Care. It's January 26th, 2023. Happy New Year, everyone. Welcome
Happy
to
New Year.
lots of adventure. Calling it. It's a year of adventure. All right. Thanks everyone for being here tonight. I think Sheriff is not here yet. I'm not sure if Sarah's joining us. I don't know. Is my mic on? Looks like it's on. It's green. Can you hear me?
No, I hear you.
Well, I'm not going to touch it. I'm going to break it. David's working. Now is it working? Well, am I just short? Because I can't get much closer to that microphone. Really?
I can hear you.
Thank you, Hal. Hal can hear me. Emmett can hear me because he's next to me. All right, thanks. Let's start again. Let's bring this Board of Trustees meeting to order. It's now 5:02 on January 26, 2023. Happy New Year, everyone. Just to be clear, Sheriff Hernandez, Sarah Churchill not joining us tonight? Is okay. And Dr. Zamora, he's supposed to be here. Okay, wonderful. Well, thanks everyone for being here. I would like to welcome our newest Board of Trustee, Councilmember Ann Kitchen. Welcome. So glad you're here with us. Or you have a cold.
Yes, but I didn't want to miss, and I'm okay. So I'm very excited. I've had a high regard for integral care for many, many, many years. And so it's a privilege to be able to serve on the board.
Thanks. I'm glad you're with us tonight. All right. Another new thing for 2023 is we now have remote board member meeting participation, and our friend Mr. Katz is a test run tonight. So
The guinea pig.
working well. Your guinea pig, yep. We can hear you, we can see you, and hopefully you can let us know if you have any difficulty hearing us or anything goes wrong. We'll continue to monitor. So welcome everyone. Let's go ahead and oh yeah, thank you. Thank you for the reminder. Lisa, yeah. Lisa's gonna spend a couple minutes just giving us the rules of the road around this remote participation. Not anything too complicated though.
No. I have 3 bullet points. So
Three
there you
bullet
go.
points.
Right. So this is our first remote meeting. Very exciting. Welcome, Hal. Glad you're the first one. The Open Meetings Act, in order to do remote participation by members of a public board, it requires that a quorum, if you serve less than 3 counties, which we do, a quorum of members has to be physically present all together in the public space where the meeting's being held. So we've got that. The other thing that has to happen is that the remote participant feed, which would be the one we're seeing with Mr. Katz in it, has to be live, and the quality and the size of the visual and the audio has to be such that the public attending the public meeting has to be able to see the demeanor of the remote participant and to clearly hear what they're saying. And so I think we're good on that. The only other thing to remember besides, having fun is that there's no ability at this time for the public to give remote comment. We don't have that at this time. We may in the future, but for now, we're still going to have, of course, people who are physically present and want to give public comment have 2 options to do that, one at the beginning and one at the end. So I think we're fine as long as we have a quorum present here in this space and we can see and hear all the remote participants. I think we're good, and that's pretty much it in a nutshell.
All right. If I could ask Hal, since you're our guinea pig for tonight, I'm going to try to make sure I'm monitoring the monitor. But if for some reason you want to break in and I haven't recognized you, please put your hand up or give me I don't know if there's a Zoom equivalent of a hand wave, but be sure and jump in. And thanks for our tech folks for getting everything set up. I know this has been a journey trying to make it all happen. And thankfully, it sounds like all the supply chain issues got resolved, and here we are. So appreciate it. All right. Thanks, Lisa.
You're welcome.
Okay, let's move on to citizens' comments. Do we have anyone here that'd like to speak to the board tonight? Right, seeing no one, hearing no one, we'll move on to consent agenda item number 3. um, Consent agenda, which is item number 3, which is the December 8th, 2022 Board of Trustee meeting minutes. And if they are acceptable, I will accept a motion to approve those.
So moved. Second.
Reverend Callahan, second. Thank you. Motion second. All in favor?
Aye.
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 All right. Thank you, Hal. We have minutes, and we're going to move on to agenda item number 4, which is our action items. We have 3 tonight. The first is our cash and investment reports for November 30th and December 31st, 2022. Welcome, Ann. Anna?
Yes, it's Anna
Ann and Anna. I have to make sure I keep them all straight.
and Honest.
Anna, thank you for correcting me.
Well, first of all, this is my first board meeting, so
Welcome.
thank you. We didn't have a quorum last week, so that's why these items are now action items at this meeting. So I'm keeping it to bullet points as well. And so with our investment report, just to note that this is the month of November and December, and that our interest rate increased from November from 3.65% to 4.3% in December. And so our total interest revenue for November was 48,256, and our interest for December was 42,585. Just to note, and I know it's in your report, but a year ago we were getting less than 1%. So the Treasury bill, this is the first time since 2007 that our interest has above 4%. So, do y'all have any questions?
Good trend. All right. Any questions? All right. I'll accept. Do we need to take these individually, or can we take A and B together? So would you prefer we take them individually? Okay. All right. I'll accept a motion to accept the cash and investment report for November and December of 2022. So moved.
Second.
Second. Thank you. All in favor? Aye. Opposed? None. We'll move to item B, discuss and take appropriate action on financial statements and budget amendments as applicable for the periods ending November 30th and December 31st, 2022.
Bella is joining me with this, so we're both tag teaming. I'm going to come across with just some bullet points, and she's going to give any more detail or anything that you might need.
Well, hi, Della.
So first of all, these are the financials for November and December. We did have a deficit, and I'm just going to speak to both financials as the end of December. We did have a deficit year-to-date of $597,479. However, as you well know, we have CCP funds from our cost report. This is the new 1115 waiver of money that we have not booked any of those dollars yet. So we are actually waiting, but as of December, that would be approximately 700,000. So our actual, I'm sorry, I wanted to clarify something. The deficit is 6,402,521. So with the 7 million, the surplus will be 597,479. I'm sorry, just read my numbers wrong. One thing I wanted to let you know about our CCP cost report. HHSC did reach out this past week, and we did have a correction that we needed to make on our cost report. Overall, now this is just on the cost reports themselves, and our original was over 21 million, but right now it sets at 20,900,000. So there was a slight reduction, but we wanted to send it with the correction. I did visit with David Whedon about what the anticipation would be with those additional dollars, because our understanding is of course, there's $500 million out there. The total of all of the centers and anyone else that's participated with the CCP cost reimbursement is less than the 500,000. They don't know exactly where that's going to fall, but we don't anticipate any haircut. So that was his words. So I wanted to make sure y'all. Okay. Overall, we have about 85 days in operating. And there's one other thing that I wanted to make note. Normally, our audit, which Della has taken the lead on, and very thankful that she's participating and taking that lead for us as an accounting team. We had to file an extension, and with David's approval, we went to HHSC and got an extension. Not see the audit until the February.
Instead of this month, okay.
For the changes, we moved, we had the cost report. It took a lot of time, a lot of changes in staffing, so that was approved.
All right. Della, do you have more to share with us?
The only thing that you have to approve is the budget amendments, and there wasn't any budget amendments in the month of December. In November, we had two, but they were collectively still, not each over 100,000. So,
Okay.
the only other thing I wanted to say is that on the days of operation, we had, as Anna just said, we were pretty fast and continue to use the daily expense average to calculate that. And so, mainly because the September and October are just very low, considerably over the average. I don't know why it takes a while to get that expenses up and going. But when I realized that we had so much increases with our class comp, I went back and calculated just to see what that would have changed to. So it's a pretty big reduction. It goes down to 74 days. So I wanted to make that note and report it verbally so you're not surprised next month as to what that change drop is going to be. And because the expense is higher, and so therefore that calculation of days goes down.
So currently what's reflected here is the 2022 average daily, but you're going to be caught up and reflecting the
Right.
current date
Right.
expense level.
We were just running, because we usually don't change that till December financials, and we were running so late, I did not catch it. And so
So we'll be catching up this month and it'll be reflected next month. Okay.
the other thing I wanted to say is that through the extension, because there was other centers that also requested an extension, normally have them present a draft to the finance committee. So all of our schedules to them were pushed back that would not happen. They would come straight to board, full board next month.
So skip the finance committee, the typical finance committee review. Our auditors will be with us.
They will present the audit to you.
Okay. All right. Questions? Anna, thank you. Della, thank you. So I'll take a motion to approve the financial statements and budget amendments as presented.
So moved.
Thank you, Mr. Katz.
Second.
Thank you, Callahan. We have a motion and a second. All in favor?
Aye.
Aye. Any opposed? All right, motion carries. So item number C, thank you very much, both of you, Anna and Della. So the next item is consultation contract for, is it Brilliant? Brilliant to conduct business planning with Connexus. Oh,
I'm gonna
Connexus
scooch
is-
over because I can't even see
I
over the
know.
line. So sad.
It's difficult for us, like, smaller stature people, right? Yeah, altitude challenge, I like that.
Good evening. I'm here to seek board approval to award a contract for business strategic planning to Brilliant for Connexus. And just by way of context, Connexus is the former, it is the local HIE and the former ICC. So it is seeking to grow. You approved a contract, a grant from St. David's Foundation for $200,000 to do that strategic planning. And this is the contract, the firm that's been selected.
And what is the amount of the,
It's $200,000.
is So it is the 200,000
Yeah.
that was approved. Okay. And how long will the project?
It is, the contract, the deliverable is July 15th with July 31st opportunity for closeout for back and forth. And the product is specifically a 3-year strategic plan with detailed action-oriented, um, you know, plan.
For the actual, like, what will happen with the
Right,
HIE, how we
right.
proceed?
What's the optimal structure of the organization, consideration of being an ASO? As you recall, it's kind of expanding from just the exchange of clinical information and aspiring to do whole health to include the food bank and Austin Public Health and other groups that really are related to the social determinants of health.
David, you're still serving on the board.
That's correct.
All right. Any questions about this contract? It sounds like it's pretty much a pass-through.
Yes, we were asked to
funds
be,
were
we
approved,
were
we
asked to be the fiscal
agent.
agent. Mhm.
Yes.
Yes, just a quick question. So the scope of the contract, it sounds like it's a plan, right? So does that include the financial aspects as well as the work steps that are involved in the timeline?
I don't know. David, do you happen to know the answer to that question?
I'm just trying to understand
Yes,
how
one of the
extensive.
financial parts in particular is
Okay.
with new board members coming on, the fee structure that might be part of the dues,
Okay,
and then also recommendations on, third-party contracts and other types of fee structures.
okay, mm-hmm,
And as you might expect, this planning will include the whole community,
sure.
all the
Mhm.
members of the HIE, as well as others that would benefit from this.
Okay,
Can you break down that acronym HIE?
Health Information Exchange.
Oh, okay, thank
Yeah.
you. I was hearing that and reading it. What does that mean? This was pretty much, like you said, a pass-through, so we're just serving as the fiscal agent for the funding to come through and to award it to.
Yes, and we are a member and an active participant. David is on the board. We are, as an organization, as Integral Care, an interested party as a healthcare provider and consumer of the exchange of data in service to, caring for those individuals in our system. We actively participate in the HIE. But for this award, yes, fiscal agent.
Yeah, and with him being on the board, that doesn't present any kind of conflict of interest in. Okay, that's what I was just want to make sure.
Yeah, good question. But yeah, thank you for the question, because we have this vocabulary that's been around for a long time and to speak. I haven't even settled Connexus into my
Right.
brain yet. It's still ICC. So, all right, thanks for that. Any other questions? All right, I'll accept a motion to approve. Brilliant to conduct business planning with Connexus. We have a motion and a second. All in favor?
Aye.
Thank you. Any opposed? Okay. All right. Thanks so much, Kathleen. All right, we're going to move into agenda item 5, which is our information items. So the first is the corporate compliance activities review and preliminary work plan for 2023. Hello, Louise.
Good evening. I'm Louise Lynch, Provider Network and Authority Officer. And here I am in the role of your corporate compliance officer, and I am going to give the annual report and review of our activities over this year. First, I wanted to orient you a little bit to your live binder. There is a spreadsheet in there that actually has the detailed compliance areas that we reviewed. It has the register for the billing and reimbursement. Just wanted to tell you there's a slight error on that. It says FY 2023 and it should be FY 2022. Otherwise, the other two reports for the HIPAA chart and the one for the compliance complaints are all calendar year. So of course, the expectations for the compliance program functions are just to make sure we have reporting systems in place, that we are providing adequate and timely reporting to the board and to encourage an accountability for our staff in terms of reporting any kind of violations or ethical behavior. So some of the items that we identified during our 2022 work plan are risks that are associated with our HHSC performance targets because we have been below targets on both our adult and children specifically. And we've been held harmless, so we know that that's an area that we really need to watch closely. We worked on the No Surprise Billing Act this year, which certainly has information that we've talked about previously, mostly about making sure that clients are fully informed by any of our billing practices and know ahead of time what they might get charged. We've also worked on the payment card industry, PCI compliance, and we've been looking at all of the reviews that we've gotten over this year, just two of them, with the Office of Inspector Generals regarding their reviews and overpayments. We had external compliance review by contractor Moss Adams, and they reviewed our telemedicine and telehealth services. You know, we had to provide a lot of those during COVID, so we specifically picked this area for lessons learned, and so we can improve our processes. We developed and finalized some organizational procedures this year, specifically ones on information blocking. And just to kind of describe what that is prohibiting healthcare providers such as ourselves from blocking or interfering with patient access to their electronic health record. So we worked on that, some of that. We're working in process with that. Also on the charity care pool, which David Whedon brought to the board, and other procedures that had to do with release of protected health information and our contract monitoring procedures. So we still have yet, of course, you know, our board policies and procedures are a work in progress. So that continues to be on our compliance plan. We also had a big group that still continues to work on the financial assessment compliance that is, you know, tied to our new reimbursement methodology. So we need to make sure that we get that down. And we rolled out DocuSign specifically for the implementation of client telemedicine consents. In IT, they've been continuing to do quarterly tests, phishing tests, because certainly IT security has been, you know, is heightened in healthcare specifically. And I've already spoke to PCI compliance procedure that's been drafted. As always, I always have a lot of fun with this Corporate Compliance and Ethics Week. And this is our meme winner for this year. I think staff have a lot of fun with that too. You know, compliance can be so serious, but we like to have fun too. This is a record of what our compliance calls look like over these few years. You'll see we start the chart back in 2018. And so we did have just a few issues this year. We have both the compliance calls and the HIPAA breach calls here. And we'll get more into that in a little bit later. Also, during the course of the year, we have our own focused Medicaid audits. We look at focused audits on a quarterly basis. And we have a threshold of about 90%. We still have a little ways to go. We also have larger program-related audits that are conducted, and those were conducted by program staff. And they reviewed about over 8,500 charts this year. So I think we have a pretty robust kind of review system with both peers, supervisors, and our specialists reviewing, as well as the oversight by the Corporate Compliance Committee. So back to those inquiries, inquiry data. We had 6 compliance issues that reported over the calendar year. 3 of those were alleging employee or provider misconduct concerning billing or documentation. 2 were related to unethical behavior or violations of policies and procedures. One of these issues was not substantiated, and they were all addressed either through employee separations, plans of improvement, consultation, or sometimes employee or provider training. And as I said, that detail of those issues are on that spreadsheet for you. For the HIPAA breach notifications, we had a total of 13 violations of confidentiality, which are policy and procedure violations, as compared to 35 last year, which is definitely an improvement. However, we did have 6 of the PHI reportable breaches that required notification. Of those, 1 involved accessing the electronic health record without need to know. The next 2 really had to do with disclosures of client-related information without authorization, either verbally or through electronic means. And then, of course, the issues are, routinely addressed through employee separations, disciplinary employee training. For our FY22 billing and reimbursement summary, there were 15 instances that resulted in about 61,000 payback this fiscal year. This is compared to 35,500 last year. One issue of note that's important in this billing is that there was about 11,000 or more in claims through United Healthcare that were denials for some reason, but because they said that it exceeded benefits. But what United Healthcare found was that it was an error, and it's widespread throughout their system. It's taken them a while to resolve the issue, but the reimbursement department is confident that that money will get paid back, and perhaps some others. So they work weekly with these insurance companies in order to try to figure out what's happening so that they can address those. For our some of our preliminary work plan items for calendar year 2023 are that we're going to step back and do a comprehensive corporate compliance risk assessment and resurvey some of our priorities on our work plan. But we do know that we're still going to do certain things that are routine and important. One of those is developing some HIPAA messaging for staff, who also continue to work on policies and procedures that are related to the Office of National Coordination. That has to do with our electronic health record, and the IT and security folks are all involved with that. So if you really want to know more, we could ask Scott about it. He wanted me to call his name. And we're going to be developing some targeted messaging concerning the differences between consent and authorizations for staff, and training on business ethics. We're going to continue our policy and procedure development and workflow. And these are some continuing items in terms of still developing that process for the health home claims. And of course, as I mentioned early in this presentation, just really paying attention to what OIG is looking at and studying, and also paying attention to our HHSC performance measures and contracts and the MCO chart reviews, which we are constantly developing work plans with supervisors around how can we improve our documentation or whatever we need to make sure that those billings are approved. And of course, your reference information again. And then I'm happy to answer any questions.
Questions? Okay, so I have one on just, like you were saying, preventing the barriers to accessing the information. As far as someone having to sign HIPAA or even medical power of attorney, are there any other areas preventing them from records or files?
Oh, for clients to access?
Yes, that's what I was just interested of. And
I don't think there's any, there's certain provisions I know that are around like psychotherapy notes, or if there's some reason that the practitioner might think or feel that the information may cause harm for folks. And there are some special provisions and exceptions. I don't have them all memorized. I'm looking at Lisa. I don't think Lisa does either. But there are some, but generally there are no prohibitions, but clients have encountered those barriers. So we're just trying to make sure that we have that all covered
access to the record.
without a
notes,
problem,
or
without,
especially if it's their that's what I was just thinking.
yes, in their electronic health record. Yes, absolutely. Yes.
Other questions? All right, thank you, thank you, Louise.
Thank you.
Appreciate you being with us tonight. Item is an update on the business plan. So Teresa and Scott, welcome.
Good afternoon, everyone.
I think
Can
I'm
you see?
a little
We should have
short.
changed, yeah.
Flip.
Yeah, we got to work this out.
I'll sit up. It'll help with my posture a little bit. Well, Scott and I are here. Oh, wait. Is it out of order?
You're on two.
Oh, there we go. All right. So Scott and I are here to give y'all the Q1 business plan update. And we thought that we would start with the work of our technology advisory committee because the projects under that are really very broad and they encompass updates for all 4 of our strategic plan goals. So Scott's going to kick us off with the technology committee update.
Thank you, Teresa. So this is the outcome of almost 8 or 9 months of gap analysis, working across all the different departments to try to understand what the issues are within the company with our workflows and current systems that might improve to help everyone. So after doing that process, we came back with 13 important projects that address things across the whole company. And so you can see them here. We went through a prioritization process, which we used the Six Sigma tool to try to make it as objective as possible to make sure that we weighted these. And then we worked with the executive team as well to weigh in on priorities based on our current goals. So you can see the 3 tiers. We broke it down into those workable chunks just to make sure that we can address it and not run out of resources while we're doing this. So these will be done, all will be done, but done in phases. Any questions on that? Okay. One of the other areas that we'd like to kind of pluck out of the business plan, we think it's important, is to kind of show some of the work that's being done on the EHR side. That's so central, it's already come up in this meeting, but it's central to the care that we give to our clients and also to the burden and workload on our staff. And so we wanted to grow tools in that arena. And you can see here is a little bit of a snippet of the Bell's AI tool. You guys may have heard a little bit about this over the last year, but it's a artificial intelligence tool that really assists our staff in their note taking. And this is a module that's integrated with our current EHR. And the outcome of this so far, we've done the pilot and we have some initial results we'd love to share because we think this is going to be hugely impactful as we go forward. So it does reduce documentation time, which we'll share some numbers here in a minute. One of the other key things is that when we submit documentation, whether it's to managed care organizations or to the government, they're looking for certain wording, obviously, and things we shouldn't be putting in there. And so with the best intentions, sometimes we do these notes and the verbiage is not what they're expecting. So this tool actually has this AI built in and it continually improves and has best practices. So it's in line with the text as the staff type. So it doesn't replace our staff in any way, but it's a supplemental tool that helps them choose the right verbiage and wording. And that really decreases also the training time when we're onboarding new staff. Instead of trying to learn this huge library of things, they have a tool that can assist them. And so you can see some of the outcomes of that. You know, it definitely helps with regulatory compliance and reporting metrics. It ultimately maximizes reimbursement because we're more spot on with what we're reporting. The staff burnout piece I mentioned a minute ago, you know, this just helps them get back, you know, their core competency is providing care. And so if we can help them with documentation. So less time doing paperwork, more time doing care delivery. And some of the results that we've seen, as you can see here, so session to sign time, once we meet with a client and we're ready to start documenting, that was averaging almost 6 hours between those two times. Now you can see that's down on average to 1.6 hours. So just a significant time. And getting started on documentation is so helpful because it allows others that are dependent on that information to make this. And then the second piece, which to me is maybe even more impressive, is once they begin typing the note, we're down to 3 minutes from 15 minutes on average, and we're just beginning to use the tool. This may even shrink more. So you can see that's a 5x improvement so far during our pilot. And just some of the quick stats, try not to bore you, but just to kind of show how this is taking off. Starting back in November, we're getting the tool settled in and getting it into the staff members' hands. We've already, as you can see, the activity spike in December. And this does not include January data where this is taking off even more. We've got 1,119 notes signed, 70 staff members, and 830 patients. So this isn't a niche tool. This is something that's really applicable across all of our care.
So how, like, I know paperwork is one of those things that people who do this work complain about a lot because there's a lot of paperwork and all that kind of thing. It takes away from direct service with a person who's accessing care. So how, like if I'm a therapist and I'm providing a service, do I get a flag that tells me that I need to do a note so that I'm reminded about that? Or how do I manage my time to make sure that the notes are done, you know, in a timely way? Because I noticed you had some stats on the amount of time between a service being provided and a note being done. So I was just curious about that.
For the most part, staff manage that themselves, so
Okay.
they keep up with their schedules and they do the notes. We do encourage collaborative and concurrent documentation, so the idea is that the closer that you do your documentation to the service, the more accurate it's going to be. So we really encourage people to start the note or the documentation process with the client so that they can have input into their note. But for the most part, everybody knows that and keeps up with their own documentation.
An important part of the work, but it also takes a lot of time. I was just curious.
It does take a lot of time, which
Okay.
is why this is really, really great because you can see just from 15 minutes to write one note down to 3 minutes.
I'd like you, well, I'm trying to get a picture of that. So the AI is intuitive, or you begin to write the note and it adds to it or completes it.
I can speak to that part. That's a great question. It has a set of boxes off to the side. So it's, again, it's an assistive technology. So when you're using your email or any of those that has the autocomplete on there, this is a very advanced version of that. And it uses algorithms and it has pre-programmed words that it watches for to encourage you change help to assist or something of that nature on a simpler term. But it has, it'll just keep getting more powerful as we get feedback from clinicians across the country, goes into the database. And it's powerful enough that it can do that in real time. So it's making suggestions, and the clinician can still override that if there's a reason to say, I'm saying this on purpose. But we also find that they're getting faster and faster simply because they already been corrected once. I think of that in my own emails, like, oh, I got to put the comma here or whatever that is. It's teaching and training you in real time. And so you don't even get as many corrections.
The IP to this, or are we contracting out and licensing for this technology? And if so, do maybe a live demo, or if there's a link where we could see kind of what that actually looks like would be helpful.
Okay, yeah, we do not own the IP. This is a national program. It's part of our electronic health record, NetSmart. It's part of their IP. But we could
Can a
certainly.
demo sometime? I'm curious about it
Absolutely.
myself.
Yeah, we can absolutely arrange that.
Is it,
Yeah, no, just perhaps at the planning and operations committee.
would it also work with dictation?
At this point is not set up for dictation. Yeah, it's all typing. One of the issues we find with dictation software, besides the clinical terms sometimes, but HIPAA, often if you're in a space where you're verbalizing certain things about a patient, then it's tough to not violate HIPAA in certain situations. A lot of times you're in a public space or near a public space.
Staff like it?
The feedback that we've gotten,
Yeah, I see some heads nodding over there. That's good.
definitely, the feedback that we've received is very positive.
Okay,
Yeah.
good.
And I think you can tell by the amount of engagement that we had. So on this slide, you see we have over 1,119 notes signed. So I'd like to think that we're getting up there because it is easier. And there's some exciting work happening in Bells. I know Tara is working on further developing it. So our group notes, which has always been very cumbersome, are going to come into this Bells AI platform. So I think we're all really excited about that one.
So it's a voluntary participation. You don't have to use the product, but it sounds like it's gaining ground just by its results. Is that fair? Okay.
We're an edge partner with NetSmart on this, so we're kind of in the lead in helping the development. Selfishly, we want to be in that position. And we're more on the forefront.
Are they using a control group for that?
We started out with a small test group, yeah, absolutely, to ensure that. Now we're trying to get it into as many people.
Go down some of the other key points.
Yes.
You just need to stop asking questions.
Yeah,
No,
I guess so.
I think it's an exciting technology.
Super excited about that one, right? Okay,
Emmett and I will be quiet.
okay.
We should have ended with this one. But any other questions?
Thanks for the update.
Can we get you guys to talk into the mic? Some folks having trouble hearing.
Yes, ma'am. Can you hear me? Okay, so Bells AI, that's a great example of some of the work that's happening under Cultivate Workforce, under that group. And we are really maximizing the use of technology throughout all of these goals, strategic plan goals. So for example, with building equity, our One Data team is working on a demographic tab that is going to go into our Power BI dashboards, and it's going to allow the managers to incorporate demographic information very easily into all of their reports. So whereas right now it's a bit cumbersome to pull out that information and merge it, One Data and Stephanie, they are building this tab that's going to be added to all the reports. So that information is going to be readily available to managers, and they'll be able to easily monitor and get that information. So that's exciting. And Population Health Department, they're currently working on an abbreviated health disparities report that is going to really help us drill down on disparities with current clients so that we can work on developing some interventions and start addressing those disparities for people that are currently open. So generally, we've looked at trends and previous, so now we want to look at what's going on right now. So Louise's team, I know, is also working on client and provider surveys, focusing on increasing the number of completed services or surveys. So they're looking at incorporating things like QR codes and different techniques, just bringing in a little technology to try to improve that. Under Deliver Quality Healthcare, we have so much work happening here. There's a lot of, it's hard to summarize everything, but we do have some optimization projects that are using the Lean for Healthcare management strategies. So an example of that is our residential unit is currently collaborating with our utilization management department, our operations team, and our app support. And they've been able to really just go through and streamline the referral process from the point of when someone calls our utilization management department to the point that the client is admitted and accepted. So the process before involved a lot of phone calls, a lot of emails, a lot of Teams messages, and a lot of calling each other, trying to catch up on a referral. But now it all goes into a form that starts with our utilization management department. It goes over to a residential form where they can enter the information in a dashboard format. So everything is just right there in front of them. They don't have to, go look for emails for referrals. It's all just there in a dashboard. And then UM is also able to, in real time, get the most recent updates so that they can just look in the chart, look at their dashboard, and they don't have to make any calls to find out the status of an admission. So we're still working through some of the kinks in the process. We're making some final adjustments, and then all of that information we're going to be able to really monitor and do QA through some automated reporting in Power BI with our new demographic tab. So it's exciting stuff.
Question on this, I was reading that I guess there's a CALM abbreviated -81 suicide prevention training.
So that is under the suicide care, the work under suicide care. We have a new training roadmap completed. So the numbers that you see in there are actually the number of staff that were trained in Q1. So in suicide care specific training. So CALM is a collaborative assessment of lethal means. So helping people be more comfortable in having conversations about removing weapons from the home and such.
Oh, okay, great. And so we have an actual team that's leading.
We do. We actually have quite a few of our staff through our suicide care initiative with Health and Human Services. We're leading what is called the Suicide Care Initiative. So we're a regional leader in the zero suicide implementation. And through that, we receive funding through the state to train our staff as not only our staff as trainers, but also 9 other LMHAs in the region. So there's a lot of work happening there. Giselle Aguirre is our lead right now. We have quite a few trainers. Yeah.
How often that those trainings happen? Like, are they monthly? And
so for our staff, I don't know the exact. We have them uploaded in the Relias, which is our training software. We have them at least monthly because we're trying to get through and get everybody trained. And then we're going to incorporate it into the new hire training only. So right now we have it happening a lot. Yeah. A lot of work there.
I have another question that you had mentioned earlier, if you don't mind me just
Okay.
asking. And I don't know if you had, the One World or One, am I saying that right?
One data.
One Data. Is that with Brittany Whittington?
So Brittany Whittington is with our Population Health Department, and One Data is Stephanie Flores. But-
Okay,
but
okay.
We
I
all,
didn't know if there's
we all
a-
work together, yeah.
Okay.
Stephanie's the brains behind the demographic tab that we're all really impressed with.
Oh, that's great. Thank you.
So along with the only other bullet point for suicide care is that we've also, with Stephanie's help, have developed a dashboard that really allows the managers to monitor the implementation of the recommended suicide care practices. So it's a lot of work, and having a dashboard just makes it really easy to monitor.
Before you move on, one
Yeah.
question. I know a lot of acronyms, but what is lean?
It's lean for healthcare. It's a technique. I, Marlene's our expert. I- It's basically a technique that helps do it. Do you want to?
So yeah, lean processes, whether it's in manufacturing or healthcare, is just a set of guidelines using statistical process control and or methods that big fancy words for just basically saying using proven methods on improvement
Yeah.
and looking for areas to kind of cut out any excess and get straight to the items that move the needle.
So lean doesn't, I don't believe it's an acronym. It just means that you try to go through your process and you make it lean. So you want to get rid of any waste,
Thanks
right?
for the clarification.
Yeah. So any waste, whether it be time or repeating processes or, could be the number of steps that people take from one appointment to the next. So it really goes through and streamlines your process. Marlene brought the technique with us from her previous place of work, and it's been incredibly helpful in helping us. It gives us the structure to really work with our teams to, at the, not just the structure, but the techniques to help us really, I don't know if this is a word, but leanify our system.
Just made up a new word.
There we go. I'd like to mention, I've also tried to incorporate this into my New Year's resolutions.
The final goal in the strategic plan is collaborate, and then this, of course, it's just, this slide probably would have been 500 slides if I tried to put everything in here, but this is just a snapshot of some of the work we're doing. Our communications department, along with a lot of our teams, participate in meetings across the city and the county and the country, for that matter. But you have a few examples here, like the Austin Public Health, substance use, misuse overdose meetings, Kids Living Well, participating in the Children's Mental Health Plan Steering Committee. We're also a member of the Austin Travis County Opioid Awareness Coalition. And then, of course, we're always continually meeting with our Texas Council. So this is just a highlight.
I'm gonna say, I was reading, I saw it's, I guess, an acronym, BI. What does that stand for?
AI,
No, it just said BI. What does the BI, the BI platform?
yes.
Oh, okay, thank you. And then I noticed it was listing, I guess, 122 communities served or based on, communities based intakes. And I just, that was trying to visualize, what does that look like as far as intaking?
Yeah.
122
So we
communities?
went through a lean for healthcare optimization project with Marlene and her team to look at the intake process. We really wanted to streamline it and make it as efficient as possible. So we wanted to basically take intake from just being in an office where people had to come to the community if they needed that. So we still have our office-based intakes, but now we also have staff that are out in the community completing intakes for those that may not be able to make it. So those numbers are just the numbers of the completed intakes that we've done. I don't recall all the numbers that I had in there, but community-based would be the ones that we actually went out and met with someone in their home, for example.
That's great. And sorry, I took some notes because my questions were just going off when
I'm really happy that you read it.
I read yeah. So I had a question because I know that additionally Integral Care has provided outreach and engagement to various community partners and community-based services and outreach and intake efforts. What are those community partners look like and what are our outreach efforts?
Did you say specifically for our intake?
It just said additionally, Integral Care has provided outreach and engagement to various community partners on community-based services and outreach and intake efforts. And I guess I was wondering what that looked like.
Oh, there you go. Thank you, David.
David West, Associate Director. Um, I think one of the best examples of that is some education that we provided to family elder care is a good example. Really being proactive, and a part of this is related to our CMHC funding, and so as a part of that work, we've been proactively reaching out and educating on the ways that we're streamlining, leanifying, of course. So far, we've reached out to 7 organizations. I wish I could remember all the names.
Oh, no, don't worry. Thank you. I appreciate that.
You have the question, Deborah?
I could go on, but I feel like y'all are going to look at me and say it's 6 o'clock. So
Let's just keep our eyes on you.
if not, I'll email the respective parties to ask the remainder.
That's it.
That was the end.
We're going to receive, under the Chief Operations Report, hello, Dawn. We're going to receive some information about the M3, the Mobile Medical and Mental Health Care Team. Thank you for this. I actually asked David if you guys would talk about this tonight, so I appreciate you indulging me.
Our pleasure. It's a very exciting program. We're happy to share it with you. But before we get to the most exciting part of the presentation, I'm going to go over a little bit of a highlight of just kind of our system of care as part of my normal report. You've heard a lot about some of the updates in the business plan. So I'll try not to duplicate that, but you'll get to see a picture of some of the dashboards in this report. So this first quarter, because we're doing Q1 reports, that screen's too close. I gotta look over there. We've seen 14,841 individuals, so that's just about 43,000 client hours. So 82% of that work has been face-to-face. 7%, you can tell, is telehealth. We're still providing some of that telephone feedback. So the majority of the services, you can tell by this graph, are falling in the adult behavioral health services area, and our face-to-face contacts are up 10%, actually, 12% from FY22. So we're trending back to that more of the in-person visits, which we've struggled a little bit over the year to do. So we're happy to see that trending in the right direction. So this reflects a lot of the hard work from the teams, just coming to work and showing up, and then reaching out to clients and making sure that they know that we're available for them and prioritizing that in-person work. We've also done a number of optimizations. You heard some of it in the business plan to help streamline some of that work along. So this is a population demographic, gives you an idea or a snapshot of kind of the population of clients that we're serving. 3% were served in a language other than English. And we'll have a presentation next month on language access, so we'll be able to update that agency language. We'll begin tracking and reporting on shifts in percents within these categories. This fiscal year, we changed our how we're tracking this information a little bit, so we couldn't do a last year to this year kind of comparison, but we can going forward. Here we have our call center, so close to 57, just about under 57,000 calls that were handled. So 48% of those were through hotline and our 988 services. Number of calls answered through 988 are limited by staffing, meaning we can take more of those calls as we have more individuals to take those calls. But we're doing well, answering with the staff that we do have. Our ability to hire remotely has really increased our ability to take these calls. That has been a nice nugget for people wanting to work remotely, and it provides space so we can really, expand that program exponentially and not be locked into a finite amount of space. 20% of those calls were for children in crisis, and we expect that to increase as we expand our crisis text capabilities. We'll be one of the centers that's piloting that work, and we know that kiddos are very savvy with technology, so we suspect that number will go up with that text capability. In addition, we dispatched MCOT 261 times. So top topics of the crisis call, we heard a little bit about AI, or our artificial intelligence capabilities through Bells, which is super cool, and you're going to love the demonstration, by the way. And we always struggle with that. And it's a good for a training tool for new employees coming on, learning how to do a note, getting comfortable. It's actually a skill that you learn and you hone. You don't come out of school with it. So I think that'll be a useful tool there. But in this instance, this is actually through our call software. So Call Journey, I believe is what it's called. So these topics were obtained through that AI software that analyze the transcripts of the call, because we record all the calls that come into the center. So it allows us to easily identify those topics. And so in that middle section right there, you can kind of see what those topics are, that 22% resource assistance, 15% related to suicidal self-harm, 13% with anxiety, 8% with depression, and then 7% were related to recent events. I almost said Councilmember Kitchen. I looked at you to go, this is our CTEC 911 work, which you were a great supporter of, and really couldn't have brought this program to fruition without your guidance and insight, and really appreciate it. So I wanted to highlight some information here for you as well. So CTEC is, don't ask me what that stands for, Mr. Callahan. You did last time, I already forgot. That's it. So it's where all our disaster planning for the city occurs. 5,216 of those calls were handled, and 3,867 individuals were supported. So that's the individuals are an unduplicated number, so some people called more than once. So 81% were diverted to clinicians for a more appropriate response. And the types of follow-up received were linkage to other integral care services.
Could I brag on the staff for a second? No, now that program, you all may know about it, but it's nationally recognized at this point, and it's, to have clinicians in the 911 call center diverts calls from a policing response, and it's just huge. And so I really appreciate the work that you all have been doing. It's taken a bit to get it up and running, and I know there's more to be done, but it's really excellent, as we can see from these numbers.
Thank you very much. We have a fantastic team that makes that work happen, and we have a really good relationship with our first responders that really brought this to fruition. So we're happy to be doing it, and it was on my bucket list, and now I'm complete. That's good. That's good.
I want you to know, I used it the other day, and it was very helpful for an individual in my neighborhood that needed some assistance.
Make sure we let the team know. All right, with our expanded mobile crisis outreach team, 1,945 individuals were served. We historically have had about 75 to 85% diversion from emergency departments. However, our diversion rate has increased in a good way to 94% due to our partnership with co-responding with the CHIP health paramedics out in the community. So that additional work and engagement in the community is decreasing those ED visits for this subset of population of people that otherwise would have gone straight to the emergency department. 100% of the individuals served who may have faced additional arrest charges were diverted to a more appropriate clinical support. So that in and of itself is monumental. So 145 individuals, just to say it by the number, were diverted from arrest, 132 from the emergency department, 285 from the ERs.
Dawn, tell me again the time period,
This is just the first quarter.
first quarter of this year. Okay,
Correct.
thank you.
And now we'll get into the most exciting part of the presentation, and we'll get out of the way. So this is our mobile medical and mental health care team. We have, come on up, Dr. Mercer. So here we have Vaughn Hancock, who's our program manager, and Dr. Tim Mercer with Dell Medical to present on this fabulous work that they're doing.
Welcome. So glad you could be with us.
Thank you. My name is Vaughn Hancock. I'm the program manager of M3. This is Dr. Mercer. I like to call him the head and the heart behind M3, mobile medical and mental health care team. Is there anything you want to say?
Yeah, just Tim Mercer. I know some of you, but for those I haven't met, really nice to meet you. And thanks so much for inviting me and allowing the team the opportunity to present this work.
Yeah.
Really, we're grateful.
Very much so. So just to kind of like highlight what M3 is, we are an intentional integrated care program, and we are meant to be integrated between many agencies, integral care, of course, community care, as well as the UT Dell School of Medicine. We are funded through a 5-year SAMHSA grant, and we're just starting the 5th year of our grant. And so all 3 of these agencies are integral to the health and the continuance of the program. And this kind of like breaks down the staffing pattern. Of course, we have Dr. Tim Mercer, who's our medical and clinical director. UT Dell provides a lead evaluator who does data analysis and evaluation with us. And they also provide a community health worker for, additional support out in the community. Community care right now is providing a registered nurse, and they're also working on plans to provide us with a medical assistant. That way our nurse can work at the very top end of her licensure, and the medical assistant would be able to help with like more scheduling and prescription kind of coordination. And then Integral Care provides quite a few of our staff, including myself, a QMHP lead, 3 rehabilitation specialists, and we also have an advanced psychiatric nurse practitioner as well. We are a community-based team, so we're out there every day. We are giving you those face-to-face numbers. I think we're probably at 100% face-to-face in our service provision. We're time unlimited. We are meant to be a multidisciplinary team, and so understanding how folks with trimorbid conditions and who have been experiencing chronic homelessness, how that looks in the community and what they need in order to be successful in their recovery. We are also an IDDT team, which stands for Integrated Dual Disorder Treatment. This is an evidence-based treatment modality meant to treat co-occurring disorders in an integrated fashion. Rather than treating sequentially or independently, we're treating the person holistically from a harm reduction and a housing first standpoint. We know that in order to meet recovery goals, you have to attend to the entire person, and housing is part of healthcare. Housing is a human right. And so we're operating from all of those issues all at once. And if you're familiar with the ACT teams, they're also IDDT teams, so we're similar to that. The thing that's a little bit different about us is that we have this medical piece. All of our clients have a chronic medical condition, at least one, that they're managing that needs specialized nursing and specialized healthcare. Our target population are people who meet that HUD definition of chronic homelessness, have at least one chronic medical condition. Often we have multiple.
Yeah.
Would you say the average is 2, 3?
Yeah, I mean, I think 2 to 3. We had data from the original cohort, and it was right around 2. And I think actually the more recent enrollment numbers, it's seemingly, anecdotally, it's seemingly more complex as the word out in the community has gotten out. So multi-morbidity for sure.
Absolutely. We see a lot of congestive heart failure, hypertension, diabetes. These are things that are easily managed when you're connected to a primary healthcare physician, but definitely difficult to navigate if you aren't. And it's also things that we know are complicated by psychotropic medications oftentimes. You also have to have that serious mental illness in order to meet the criteria to be served by integral care, and a substance use disorder. So we're kind of like, we're definitely working with a really difficult and chronic condition population, and we're trying to help the sickest of the sick. We prioritize our African American clients in the community primarily as a way to disrupt racial inequity that has existed in traditional medical systems. Currently, this number changed yesterday. We're now serving 44, so just to give that update. And M3 enrollment just reached over the 50% mark of serving African American clients. So we have our racial equity broken down, but I didn't bring that with me today. This graph you might have seen going around. This is data from the 2020 census, as well as the point in time count, which is occurring this weekend. If anybody's going to be there, I'll see you there. So we have data from our neighbors experiencing homelessness, and we also have just like Austin, Travis County metro data here. And this just demonstrates the racial disparity that exists in the population of people experiencing homelessness. Black folks make up about less than 7% of the Austin, Travis County population, but they make up about 35% of our population experiencing homelessness. An integral care client, just to give you the numbers, a Black integral care client is 1.67 times more likely to experience homelessness than a white integral care client. And so again, this is why we are prioritizing our Black clients that meet the criteria. These are our goals. I imagine these are a lot of folks' goals. And the things we really want to highlight here is we are operating from a harm reduction model in all aspects: mental health, chronic medical conditions, substance use, and homelessness. We're attempting to decrease those emergency department visits, those EMS presentations, and we're really trying to increase connection to stable medical treatment as well as stable housing. This is what it looks like in the community. These are a couple of our folks. We've got our nurse, Ashley Sharma, there, and then we have our team lead, Tony, with one of our M3 clients who was featured in the Austin Statesman, I believe in January. We meet our people where they are. So that might be out in the community, it might be under a bridge, it might be at a food establishment, any place that they feel comfortable that we're able to provide services safely. And that also means that we tend to provide support in vivo, attending appointments with people, being kind of their eyes and their ears, reminding them of symptoms that they may have been complaining of, reminding them, hey, tell them about this medication that hasn't been working well for you. So being kind of that person in the room with them, advocating with. We are an integrated model, and so the way that we do that is communication. That's the only way you can. And so the documentation is so important, but we're also doing a lot of verbal handoff. We're doing a lot of reminding. We're doing a lot of cross-training. We do a weekly all-staff meeting with clinical and non-clinical staff, which is so helpful when you're thinking about data. Just yesterday, we had this great conversation about, is our data really representing what we're attempting to ask? And so looking into that and making sure that the tools that we're using are really going to represent what we want them to. Some outcomes. Our depression measures are showing a downward trend. People are reporting a less depressed mood, more stable mood affect, and higher functioning in their overall life. We're also seeing some decreases in the substance use ratings. We do know that the real marker is going to be at that 24-month mark. Working with us, we're going to start to see like some sustaining change there. Until then, we'll really have to continue to go back and check in with folks. We are hearing anecdotally decrease in the high-risk use, and so that's one of the things that we're going to attempt to increase our understanding of with our measurement tools. And then here's like the real kicker. Our ED presentations are down significantly. I think one of the numbers that we have is that it's down 63% after working with M3 for about 12 months. We are seeing that connection to community healthcare as an improvement and being able to access more appropriate and I would say like more effective medical treatments. We are seeing an increase in hospital admissions, and one of the things that we think might be happening is being able to have a team that has the client's history and the medical terminology and support. We're getting more admissions for things that really did need admissions, using the emergency departments more appropriately and effectively with the clients.
some of the challenges, all the challenges that we faced, I'm sure, like as an agency, we are really dependent on being able to meet our people face to face. And when they don't have reliable technology or communication devices, this is really hard. So what this looks like is like getting to know getting to know your person really well. Like, oh, they're not at home, let me go stop by the store that they usually hang out at. Let me see like where they might be in the community. We're also working with folks that are not as mobile as some, and so being willing to meet them in their place of safety. What's next? We recently started groups. We started groups in October of 2022, and right now we're providing 4 weekly groups that are done at the Taos building over there off of Oak Springs. We also are partnering with Taos to provide a weekly food pantry. We are offering 90-day respite stay beds to stabilize and begin the substance use treatment kind of path. And we've had some really great success with that. We've had 2 M3 clients go through the 90-day respite stay, and their lives are just markedly different. And it was what they needed. And if they hadn't had access to that, I don't know that we would have gotten as far as they would have been. So very thankful for that. We are just building a more reactive and flexible model, having our APN go out in the community and offer those services has been really helpful as well. And we have a counseling intern for 8 months that's providing individual counseling to folks that have probably never met with a regular counselor. And so seeing a lot of trust built through that endeavor. Anything else you want to add?
No, I don't think so. I mean, I think, yeah, Vaughn hit all the highlights. Thank you again for the opportunity to highlight this work and really take the mentality that no problem is not our problem. And that's the target population we're focusing on, those, with homelessness and trimorbidity, and really trying to holistically address their needs in an integrated way. And the support of the institutions like Integral Care and to work, across boundaries with other institutions in the community, I think is really transformational. So thank you.
Well, I have a bunch of questions, so I'll just ask one or two. Um, um, One of my questions is the relationship with housing. So it sounds to me like, if I'm understanding correctly, this program was not funded for housing. Okay. So there's no dollar amount through the grant. So what you have to do for housing purposes is you're connecting to other resources in the community, right? Is that right?
That's right. Yeah.
Okay.
We assist in the navigation. We partner with ECHO. We also, we do have some rapid rehousing funds, but that
Okay.
is not meant to be sustainable. It's meant to be, like transitional and getting folks connected to those permanent supportive housing.
Okay. Are those funds part of the grant?
No, they are not.
Where are they from?
Integral Care, or I think it's a city program.
Is it the city's program? Okay. And then I'll just ask one other one. So of your clients, how many of them are housed?
Currently?
Yeah.
Well, they all start unhoused.
Well, I know that,
Yeah.
but I mean, the 44 that you have now?
Right around 70% we've navigated into housing. So
Okay.
we've been very successful navigating into housing, I think, through this sort of no wrong door, no problems, not our problem approach, integration, building the community relationships and trust,
Okay.
and just the testament to our staff who just work so tirelessly to do that without dedicated housing dollars.
Okay. And then did I hear you say that this is the 5th year of a 5-year grant?
That's right. So we received the grant in 2018. It took us about a year to write the protocols, hire the staff, do the training, get all the stuff in the back end to integrate the systems, communication tools across agencies, et cetera. So started enrolling. I think we enrolled our first client in August of 2019, if I recall. We all know it happened in early 2020. Rode that wave, had to pause enrollment there, adjust our model, started enrolling again. Then we, as many have, had staffing challenges and were without a nurse for quite a while and couldn't really enroll anyone during that time period. But then we're able to staff back up, and so have picked enrollment back up again. So we're really in a kind of a back into a rapid growth phase. So yes, we're entering year 5 of the grant. We expect there will be some carryover funds as often is, so working through that. And SAMHSA just released a couple RFAs for similar types of grants for another 5 years, which we'll of course apply for, but also, discussing with community partners about additional
That,
funding.
that was really my question. You can't stop. I mean, this is a great program.
And just to, 44 currently enrolled, it's sort of as we enroll and things is changing, but roughly we've had about 200 patients referred, about 70, 75 ever enrolled, 44 currently enrolled. So that delta of whatever that 28 or 29, it's about a third of those who have, between the ever enrolled and the current enrolled, about a third have graduated, reached a level of stability, housing, symptom improvement that they don't need us anymore, which is the ultimate outcome. About a third have been lost to a follow-up and a third have died.
Okay. Okay.
Thank you.
Question. Mentioned a stat early on about just within the Black community of housing versus whites that are homeless. What do you feel has been like the service area gaps of that chronic homelessness? Like, are they not qualifying for housing? Are they not eligible for? Is it just lack of housing? Like, why?
I mean, even the most privileged among us, I think, in Austin are struggling with housing. And I do think that overall, we're seeing a big demographic shift. I don't feel comfortable speaking directly to that question without some data to back me up. And I hope someone is doing this research.
And I was also going to ask, I guess, with your providers that are providing the services, do they have experience with the BIPOC community or representation? I know I saw the image that was depicted on kind of out in the field, and it would be great to have a little bit more inclusive images of if you're serving 50% Black people from the 7% that is actually in Austin, what does that look like? Because I didn't see any images of that.
Yeah, and we really try to operate from the client choice perspective of, would you like your picture to be included?
Oh, okay.
Something that you're comfortable sharing with folks. And so when we reached out to folks for that media opportunity, we really did want to make sure that we were giving choice there, just to be like really transparent.
Yeah, that makes sense. And then my last question was, are these people, how do they elect to be a part of this program? Are they off the coordinated assessment list that are on the wait list for housing? How does that happen?
Most of our referrals do come from community care. At this time, I believe 40% of our referrals have come from community care and integral care. Yes. And so working with providers who are already involved in providing healthcare for the homeless is often the way that we come into contact. And so anyone can be referred, and then we make sure that they meet the criteria that is outlined through the SAMHSA grant. And we begin contact through that referral, and we do a warm handoff and make sure that we introduce ourselves and pick up where they are in their treatment rather than having them start all the way over.
And just a follow-up, so is that how do you prioritize their housing needs versus those that may be on the coordinated assessments list for years? Is it and I would love to see the criteria.
So, yeah, it's integrated. So we get, most of the referrals come from within community care, integral care, but we've gotten referrals from community health paramedics, just about any homeless service organization in town at this point, Front Steps, Family Elder Care, et cetera, the hospital. So sort of getting the word out there. And then we get the referrals. Based on the criteria of meeting M3 eligibility, they're all at the top. If they haven't gotten a coordinated assessment, we're getting it done for them. And if they have got it, most of them are scoring towards the top of that list based on their multimorbidity.
So how do you prioritize is what I'm wondering. How do you judicially kind of say this person gets housing versus that person? Because I know that sometimes even within systems, there can be that level of where does
we don't make the housing decisions, right? We're just navigating them into existing housing programs.
Okay.
Deborah.
Yeah, so thank you, Dr. Mercer. No, I think you actually answered it. They are at the top of the priority, but they are not the ones that are managing the coordinated assessment or that list, right? That's done through a different process in the community through, ECHO's handling that list. And so Individuals, fill out an application, it goes into them, they assess based on criteria around their needs. And then that's how they show up on the list, and then they're referred out from there to various programs. Um, they're not necessarily referred out to them for services, right? So we have engagement folks that are out in the community because their role is not necessarily to be providing permanent supported housing or affordable housing or rapid rehousing, but they're connecting clients to those resources to get them there. But we have those resources. So we have Terrace at Oak Springs, and we have several community-based or scattered site housing units that we can use our rapid rehousing vouchers to get folks in while they wait to see, can we get them into PSH? Do we have an opening there? And then we transition them from that voucher to a different one. So they get that full level of support. This is kind of a gap, right? This program is filling a gap that the system has. But your questions are spot on around kind of that eligibility criteria. Are they culturally and appropriate around equity, and how do they measure that? And actually, we, through our HCC grant, we provided a staff to ECHO to look at those very things, and they're tracking it in their dashboard to be more mindful about those, to make sure that we're opening access in areas where our community traditionally has not.
No, that's great, because I know that, I guess, the eligibility, I would love to see that, only because when you're in need of housing, it's immediate, right?
Absolutely.
And then you have to fill out some long hoop to go through to be applicable. And then when that's judged later on, if you meet the criteria or not, who knows how long that is? And then they tell you, oh, you don't, and you have to hop out of one line to go to another.
That's
So it'd be great to know, how does that eligibility process looks for those that are in need, to where maybe that's up front, or, I would just love to see.
No, I
see that.
support you and hear you 100%. Unfortunately, that's not necessarily our area, but we do work with other agencies that are doing that work, and we're happy to set up a meeting if you'd like to have that conversation.
Oh, I
in more
love that.
a smaller setting.
Can I ask a quick question, if you were at capacity, meaning you couldn't take any more people, what is the number for that? How many people is that? Are you at capacity
With
now?
the staffing model
44?
currently, really what we've learned is the way the team's current structure. I mean, you saw the staffing, a number of staff from integral care, QMHP, case managers, housing stability, a peer. Their primary care is provided through the Healthcare for the Homeless program within community care. I'm the primary care doc for most of these folks, but not necessarily. That's not a requirement. The rate limiting step in the current staffing model is having one nurse. So we think it's about about 50 clients with our one nurse. We're adding on an MA care coordinator. It's literally like funds are there, it's just in contracting hiring. That probably won't double our capacity, but it'll probably bring us, my estimate is maybe bring us to capacity to be able to handle 70 to 75 with how things are currently, because that can take off a lot of that care coordination work from the nurse and allow the nurse just to do nursing. And then I think from there we continue to scale. So, still relatively small numbers, but this is one of the most complex and vulnerable populations in the community. I mean, we're averaging like 2 touch points with patients per week, just to give you a sense.
Incredible.
That could be a phone call, that could be an accompaniment to a cardiologist, it could be a visit with me, it could be a visit with, accompaniment to the food stamp office or whatever. But, so it's an intensive sort of service delivery model to meet all these needs.
Well, I just want to say thank you so much for all you're doing. It's very impressive. The reason I ask about capacity is I was trying to figure out how can we get more of you. So, and I know workforce issues are huge, like recruitment and retention is huge. And I imagine, if you're out doing this work, you really have to be so passionate about this work. And I can see that you both are, and I think that's incredible. And being able to use peer support specialists and community health workers in addition to the work that you're doing as clinicians is just spot on. So I just want to say thank you.
I would love a copy of your presentation.
And I'm happy to.
Oh, yeah, I would love that. Thank you.
Thank you so much for being with us.
Thank
We really appreciate it.
Anne had a
I
question.
have one last question. And actually, this may be more for David. I assume will let us know how the funding works out. Maybe this is a question for Dawn. And if there are any concerns about continuing. Okay, thank you.
Thank you.
Thank you so much, Dr. Marcia. Thank you, Vaughn. All right, we're going to move on to, Fort David's got a few items for us tonight.
Thank you. Just a couple of quick anecdotal remarks just in this this most recent presentation is one is that we appreciate the Dell Medical School. At some point, we'll have to add up all the ways that they're making us better through the collaboration and close working relationship. We are planning currently with the new dean, Dr. Lucinelli, a visit, and we're going to be sure to brag on this one program that we currently have in place. Also, recently, the regional administrator of SAMHSA heard about the good work in Austin and called and said, could she come and look on, at the services on the ground as to what it is they're funding and doing. And she spent all day yesterday with us. And so the administrator, Ms. Brooks, yesterday, I think toured some 4 or 5 of our programs. So what does that mean? That means that we're just trying to work as close to the top as possible and make the point that you're making that we need a continuation here. Very briefly, I put 4 areas down on my report for this evening. And just in the way of the first one, first quarter CEO report, the 12 SMART goals that you've established for this fiscal year. There's been a first quarter update on each of those. I'm not going to read back through that this evening. There is one, however, number 4, that I just would like to touch upon a couple of things. This is to reduce by the end of the 4th quarter, so this is just the 1st quarter, and demonstrate advancement of collaboration with the city and county and state stakeholders to implement strategies and design policies that reduce incarceration of individuals with mental illness. Due to the good work of our staff and putting proposals together in the 1st quarter, the county increased our funding by 50%, an additional $4 million that has a direct impact on individuals being diverted from going into jail-based programs. We heard about that collaboration with the city and Austin Cares this evening with data and a continued move forward with our Austin Police Department. Interestingly enough, the Community Advancement Network that Hal Katz represents us on at this last month's meeting mentioned that their goal, a council member, Fluentes, is this year's chair. Ann Kitchen was a past chair of the Community Advancement Network, and her goal is for each of the 27 agencies participating to have a core class in mental health first aid in promoting that outreach. So you'll hear through the year, this is the 1st quarter, but you'll hear the work with the Dell Medical School leading a steering committee on forensic services and planning and a set of recommendations coming out that includes a number of areas like going to scope on our mobile crisis outreach team, being able to look at some of our existing facilities and what we're learning on visits to Miami, Tucson, Nashville, Harris County. Are there some things that we could incorporate within RPES, urgent care, and then utilization of our residential treatment at Herman, the Inn, and also 15th Street. Just interesting to note, you may or may not remember that at the Heron Center on 15th Street, that facility in part came from the Psychiatric Services Stakeholder Meeting that our chair chaired at the time. And that's also being looked at and as to currently if it was funded to incorporate some of the changes that the city and county would like to see to be able to take on more diversion activity there. So, again, I'd answer questions on these. This number 4 is one we could talk a lot about in terms of our 4th strategic plan area and collaboration. We're collaborating on that steering committee, a reentry roundtable, Austin Cares, and the Behavioral Health Criminal Justice Advisory Committee. It exhausts me just to read all of that off, but it's all in play. And city council members, county commissioners, and elected officials are in each of those areas of work. Just for level set, I just would mention, and I know everyone knows this, but I just saw it over and over this evening. The strategic plan is a board policy document. We're in the first year. This is a 23 to 25. I keep looking up because the 4 goals are there. As presentations went this evening, the budget operationalizes that strategic plan, and then we've given you an accountable business plan for implementation. So we've referenced back through those budget and the alignment with those business plan recommendations. Next of all, Reverend Callahan is our lead and representative on a 39-member board, which is our Trade Association Texas Council. He's been faithful in that. Thank you. And I think you've tonight have in front of us a report from the recent quarterly meeting.
That's correct. Thank you, David. And, excuse me, I was out ill this weekend. I was unable to attend the board meeting, but I did summarize some of the highlights from that meeting, thanks to their staff. What you have also, and I think Misha shared with you, things every board member should know and back home. That document is one, and I tried to correct it on the handout that I gave you. The Frank M. Adams Award time frame was changed from January 31st to February 14th. So in order to give our staff time, senators time to get their applications in for that award, because the conference is coming up, I believe, in June. Next quarterly meeting is in April of this year. But it was good. Any questions on that? I've tried to send you all the information I get from the council via email, and I do need to get our new board members' email address to make sure that you get that information, because the Texas Council report was pretty lengthy. It's about 12 pages, but very in-depth. Good information to have about what's going on, especially with the legislative session going on right now.
Mm-hmm.
So, any questions about that?
Thank you for the summary. It's really helpful. And I really do appreciate that what we should be talking about back home. It's very,
That's a
very
good document.
assistive. Yeah.
While we can't lobby, our Texas Council does have the proper credentials to provide and represent us in the Texas legislature. And this is for upcoming board meetings, but I do think we need to be agile on this one point around the budget. As you've read and know that they've entered into a projection from the comptroller on some next biennium of $188 billion. Maybe even more significantly is they have a current carryover in the current fiscal year, a projected $32.7 billion surplus. They also have unexpended ARPA funds. And this is being talked about as a once-in-a-lifetime opportunity. In terms of just workforce, and I'll just make this as brief as possible, already embedded in the budget. Usually this would show up as an exceptional item request, but they've lifted up for the state employees. We're not necessarily competitive, but there's a limited number of clinicians in Central Texas, a 5% increase for FY24 and a 5% increase across the board in salaries in FY26. So the point I wanted to make about upcoming and why I wanted to alert the board to this is that because there's a cap on the amount that the legislature can increase their allocations, one of the strategies is to look at supplemental budget within the current fiscal year and make available grant funding possibly to community centers. So what we're evaluating is if there's match requirements, or what level of unmatched funds do we have, and would we be ready to step up with any other shovel-ready projects that could receive some immediate attention and funding. So we're analyzing that currently. And again, we only have so much capacity. I think you've heard about all the hard work tonight, and I don't want to wear staff out as I'm saying this point, but nevertheless, we are trying to prepare for any opportunity that may be there. Next, I'd like to just mention that we had on our second Tuesday of January, we do each month, our meeting with the United Workers of Integral Care. And at our collaborative meeting that was held on the 10th, I just want to hit a couple of items and recommend to you that the union has, I think, really entered in this in a way that each of the items they bring up are for improvement of our operations here. So these are the things that we're currently in dialogue on. A facilities reporting process. I think this is part of the value of the union. If someone would ask me, do our employees know what we're doing in the way of building repairs and modifications, I'd say, oh, yes. But as it turns out, there's a lot of questions on the speed at which these projects are being taken on, where there has been noted different construction projects. We really did, I think, hear and try to respond, and we reported back that we're identifying in each of our 45 facilities that there would be a lead staff person that would have access to a new software maintenance program that we called, and I don't know where this name came from, Scott, but Maintenance X. And what this does is we'll give these users from every building or every program an opportunity to look right into the work orders and the progress that's being made and next steps on each of the renovations or modifications or improvements on the building. So this is yet to go into full effect. We're looking at some additional training on the use of the software, but this will keep some of these items on the agenda. It's not one and done, but to continue to hear from our employees and think through ways to better communicate. We discussed pay raises and the timely of pay raises that are here. And, our response in our meeting together is the next time we'll be discussing pay will be within our budget process for FY24. We also talked about the union promoting that the cost of living continues to rise. And while we did some increases this year, that we should consider those again in the upcoming budget process. And there was also a request that rather than looking at percentages of pay increases, to maybe look at flat rates, because in some folks' opinion, the percentage actually even drives further apart increases based on current level of wage. They also asked for a regular update on our turnover reports and also an update on all employees. Rodney Gwynn, our Director of HR, has provided those reports, and we'll make those transparent reports available on a regular basis. I would note on turnover data, we're refining with a clearer picture by stratified reporting, and you'll see here regular quarterly reports on turnover. A couple of pieces of good news. This doesn't tell the whole story, but a couple of snapshots is that we continue to have a turnover rate that drops, and we hope we get back within that pre-COVID range. Just one example is that on this day last year, we had 298 openings posted, and we're currently running 172. That's too many. Those are gaps in services that we're not providing, but nevertheless, it's trending in the right direction. Also, I would mention that we had a lengthy meeting with lots of topics. We're going to have a standing agenda that these won't, again, all be finished. But there was a request that we clarify the position here on our ombudsman. How does that work? What's the flow? How do we close out cases? And I'd like to thank Louise Lynch for her presentation and update on that process. New items, employee satisfaction. The one area that was noted that we need to improve on, some input from our employees saying that communication from senior leadership is an area of high dissatisfaction. And, we were reviewing the fact that we have a weekly newsletter, we have All Things Integral, we have a HR newsletter, but maybe those aren't the best ways to communicate. We need to listen and understand where there's an unopened rate of emails. Imagine your surprise. Email from the CEO. It's not funny. I'm just thinking, that it's what gets clicked open and what doesn't. So There was another issue which had to do with at-will. Texas is an at-will employer. And it also had to do with the fact that just fear of termination without further due process beyond how we currently do a positive performance plan. We did talk about that we do have a final approval for any reduction in force or any individuals that are being let go by Lisa Lakey and Rodney, and not everyone that's recommended for termination, after they review that, they may go back and say the documentation is or isn't in the file on that process. The last area I would mention, and this has to do with a scheduling policy, and we've been trying to create open access at certain times where we allow for just-in-time walk-ins. And that process has created a certain number of questions and an impact on employees in the clinics. And so they want to continue to talk about any data that we have regarding how that process actually runs through and number of individuals utilizing it and what some of the outcomes. So that is going to stay on the agenda and supply more outcomes. So again, I've already mentioned the union request that we would continue with items that are unfinished on the agenda in the way of a standing agenda, and then also continue to look at any other alternative methods to a termination process. Anyone has any questions or comments, but wanted to report our union activity.
And remind me, this will be a monthly meeting going forward now that
Yes.
it's established?
Second Tuesday afternoon each month. Last area I have is just looking ahead, and three things really quickly, and it'll close out any questions you may have. I just want to underscore, emphasize the Central Texas African American Family Support Conference. Emmett, I don't know if you want to comment on it, but you probably already know that there's 680 people. We've had to close off the number that can attend in person. But the uniqueness this year of going with a hybrid broadcast, anyone in the country or world really could tune into it. And we've had 180 people registered to attend online only.
The only thing I'll mention is the high anxiety for having both a virtual and in person.
You promoted that.
A lot of anxiety. So it is such a great relief gotten to that place and really understanding the traction that the conference is, and I do expect it to continue to grow.
So again, I'm sorry, I just want to clarify, David, it was 680 in-person registrants plus 180
Yes.
online?
Yes.
Ooh, okay, thanks.
I just want to say I'm really looking forward to the conference, and I would encourage everyone, board and community, to know that even though the title's African American Conference, all is welcome, and to take it a step further than just invite, offer to register. I've signed up people and said, if you want to come, tell me, and I'll get you registered, and go on there and register them and not actually leave it to them to do it. And so it's great. It's transformational. So I hope everyone tells people, come, all races, all colors. We can all learn from one another.
And thank you for all your hard work.
Sure, it's a labor of love. Luann just reminded me of our board challenge. I can't remember exactly, but I think we nailed it.
I think
we nailed that challenge.
Just making sure.
Yeah, yeah. 'Cause
Yeah. Yes, 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 yes.
I get a feeling that if we didn't nail that, I'd be hearing about it, so. But I thank each and every member's contribution, and Reverend Callahan has a standing contribution. It supports housing for those who are coming in to participate. So it's just really great to have that kind of.
For inviting us to participate.
Or doing it again next year.
All right, that's coming up, week after next.
Mhm.
And my anxiety's high. That's
Oh, yeah, oh, yeah, oh, yeah.
All right.
Trish, before you, are you about to close?
We have citizens' comments next.
Okay, before we go to that, I just want to publicly, I read Kathleen Casey and Marlene Buchanan were appointed to Amplify's advisory board. So congratulations.
Oh, nice.
Yes.
Thanks for sharing
I
that
thought
with
that was awesome.
Yeah. Okay, any other questions, comments? Then we'll move to citizens' comments. Do we have anybody that would like to visit with us tonight? Citizens communication? Oh, okay. Oh, yep. Hello.
I'm Megan Moriarty with United Workers of Integral Care. Thank you for reporting on the consultation meeting. I'm really encouraged by the meetings we've been having so far, and I appreciate that we're collaborating together. Just wanted to make like a slight clarification about the item of the facilities reporting. That was less to be kind of aware of the construction and building that's happening, and more for staff to have a way that's clear to report any concerns they have in facilities. For example, if there's something that could be disruptive or harmful to staff or clients, like if there's a concern of mold or rats or something that could be dangerous, just a clear way to report that, and also to have transparency, knowing that you're going to get a response and updates on it. So I'm very excited to see how this new software is going to work. Thank you.
Thank you. Thanks for clarification, Megan. Okay, well, thanks everyone for being with us tonight. Welcome, Councilmember Kitchen. Glad you're on board with us, and we're going to adjourn this meeting at 6:52. Hal, thank you for being our guinea pig. It went.
You guys were very gentle. Thank you very much.
Yeah, we're glad you could be with us, and again, thanks for hanging in there on the screen. Appreciate it.
Have a good night.
All right, everyone. We're adjourned, and we'll